On to the next one. So these are my disclosures. I'm employed in the Institute of Psychiatry, Psychology and Neuroscience at King's College London. I work in King's College London. I used to work only a mere 800 miles from Professor Greenshaw, and I have grants from various societies. So let's kick off with the scope of the lecture, which is about essentially mood disorders. As you can see from the schematic, with the global burden of diseases, and this is the update from 2019, the center of the teardrop is depression and anxiety, with bipolar disorder being the green on the outside. Throughout the lifespan, mood disorders are the largest single contributory category or categories to the proportion of mental disorders global burden of disease. You can see depressive disorders itself is over 37%, anxiety disorders close behind, and both really dwarf schizophrenia. The burden is due to mental disorders being present across all age groups, although of course this is greater in the first half of life. For both sexes, disability-adjusted life years increased steadily during COVID, and adolescents, they peaked between 25 and 34. And though they decrease after 35, you can see there's still a very significant tail into older age. And of course, note this is 2019, and this is before COVID, and we will have seen an exaggeration of the amount of depression and anxiety, and a diminution in most countries of the ability of services to deal with them. Here's a classification of mood disorders from my colleagues in Australia and New Zealand. And as you can see, it starts with a split into depressive disorders and bipolar disorders. These are, of course, closely interlinked, with major depressive disorder often unveiling as bipolar when there's an episode of mania or hypomania. So the bipolar disorders are a group of disorders with bipolar 1, bipolar 2, and cyclothymia. But the predominant burden is major depressive disorder. And really, persistent depressive disorder is a chronic variant of that. Disruptive mood dysregulation disorder is somewhat of a curiosity, given that it was created to solve the arguments or resolve the arguments about childhood onset bipolar disorder. And then we have secondary conditions such as premenstrual dysphoric disorder, substance use, medication-induced disorder, and mood disorder due to a medical condition. However, most of this lecture will be about major depressive disorder, but bear in mind that what usually is trialed as a therapy in major depressive disorder is then either trialed or used, even without being trialed, in major depressive episodes in bipolar disorder. The other thing which is advancing is our knowledge of the genetic correlation between mental disorders. Much of this actually confirms what we already knew from the careful family history studies dating back a century or more. But you can see the genetic correlation is greater with the color of the line, the darker color being the stronger correlation. And you can see there's a clear genetic correlation in this paper from Nature between major depressive disorder and bipolar disorder. But note that major depressive disorder is more correlated with anxiety disorders, particularly generalized anxiety disorder. And bipolar disorder is actually more correlated with schizophrenia than it is with MDD. So these disorders, particularly major depression, really sit at the heart of psychiatric practice. Now, deriving from Angst, Akiskal, and others, Benazzi, you can see here, we think of mood states as being a spectrum. So we impose categories such as bipolar 1, bipolar 2, MDD with mixed features, non-mixed MDD. But really this is a spectrum, a continua of clinical disorders. And this was well captured in the old category, first coined by Kreppelin, of manic depressive illness. The symptoms of a major depressive disorder are over-inclusive. This dates from DSM-3, and this is really something that's been criticized by Ed Shorter from Toronto. The DSM-5 criteria are essentially very similar to those first introduced by Spitzer and colleagues in 1980 with DSM-3. 2 hallmark symptoms, depressed mood or anhedonia. You only need to have one of them. And then a number of other symptoms, weight change, up or down, sleep problems, insomnia or hypersomnia, psychomotor problems, fatigue, psychological symptoms such as feeling inappropriate or feeling worthless or inappropriately guilty, thoughts of death, and cognition. Now, because of the variability in these symptoms, there are hundreds of different symptom combinations to actually satisfy the diagnostic criteria. And because of this, Shorter, I think very rightly says that this is a heterogeneous ragbag that lacks specificity and really should be subdivided. Now, in DSM-5, they've introduced specifiers, which specifiers such as with anxious distress, mixed features, and so on, which do allow sub-specification. But this hasn't really worked through in a very meaningful way to the trial literature, but that should happen at some point. So not only is there heterogeneity in the symptom presentation, there's different tracks in the trajectory. This is the famous Eaton study, which is a prospective population-based cohort study of 23 years follow-up of almost 3,500 patients. This is a remarkable study which gives us much of our information about the nature of depression over the longer term. So you see that 50% over the course of 20 years follow-up had only one episode, and that's usually between 9 and 16 weeks. Of the other half, 35% had recurrent episodes, and 15% had an unremitting course. That's essentially what DSM-5 now calls persistent depressive disorder. Median time to recovery was 2 to 3 years, but that's not really that meaningful a statistic. If you look at the group who had one episode, it was generally much shorter, and of course the unremitting course group had a much essentially infinite time to recovery. The risk of recurrence increases after each subsequent episode, and only younger age of onset significantly predicted recurrence. So these are the specifiers, which I think may be some degree of an answer to Ed Shorter's criticism of major depressive episodes and major depressive disorder being too big and over-inclusive a bucket. And you can see that they are classified by severity. So you can classify the episode into mild, moderate, or severe. You can then classify remission into partial or full. It can be classified as on illness pattern as single, recurrent, rapid cycling, or seasonal. Rapid cycling technically only applies to bipolar, but very occasionally you get rapid cycling unipolars, in my opinion. Onset, which can be early, late, or peripartum, and then the clinical features, which are put on top of the classical DSM-3 to DSM-5 criteria: anxious distress, mixed features, melancholic, atypical, catatonic, and psychotic. Psychotic, unlike the practice in large parts of North America, should be categorized as mood-congruent or mood-incongruent. That's very important. And anxious distress, again, these can be mild, moderate, or severe. There are particular complexities in the diagnosis of bipolar depression. It evolves over time, and 2/3 will present with initial episodes of depression. So this means that, to my mind, major depressive disorder is always a provisional diagnosis because it can unveil itself as being bipolar, either because the history of hypomania has been missed, and we see this very commonly in bipolar 2, missed not because the doctors don't ask about it, because very often the patient doesn't want to reveal it, or even normalizes the experience. This means that the initial diagnosis can take up to 10 years, with people presenting with any symptoms of mental illness, full episodes of depression, symptoms of mania before the first full episode of depression. Comorbidities are common: substance misuse, alcohol misuse, anxiety disorders, ADHD. The full panoply of psychiatric problems are very common as comorbidities to bipolar disorder and complicate the diagnosis. Now, this is our current UK Maudsley treatment pathway for people with major depression. This, as you can see, is pretty similar to, I think, what they do in Canada, Andy. The key thing is initially screening for depression and diagnosing depression, and then treating first line with one and then a second SSRI or SNRI, and then there's a carousel of different options, including switching within the same class again, but we know from STAR-D study that that's only likely to benefit about 13% of people. Combining psychotherapy like CBT or two antidepressants, with the only evidence-based combination being mirtazapine with a reuptake blocker, or augmenting with atypical antipsychotics, lithium, esketamine, thyroid, and so on. Now, non-pharmacological therapies should be included as part of the treatment plan for psychotherapy at any point from the beginning to the end. My view is that very often, if the person is too severely ill, then they're not really able to utilize the psychotherapy, and that should wait till symptom improvement. Then after remission, you should maintain treatment for 6 or 9 months for the first episode, and for at least 2 years if the risk of recurrence. And some patients may need to be on treatment for a lot longer, as recently shown by Professor Glyn Lewis in his New England Journal of Medicine paper. Now, the challenge of MDD, even though we do have the pathway, is that we're really not very good at dealing with it. So despite being a leading cause of disability, only a minority of patients worldwide receive minimally adequate treatment. In high-income countries, this is 1 in 5, and in low-income and middle-income countries, that's 1 in 27. Now, that's a paper from Graham Thornycroft from 2017, actually based on data that's a bit older, and I'll come up to a more up-to-date paper in a moment or two. But just to say, the barriers to treatment seem to be present in both countries: scarce mental health services, lack of awareness of MDD as treatable, and of course stigma and social exclusion, which are often reinforced by the media and so on and so forth. Now, this is our more recent examination of care pathways for people with major depressive disorder. This is a European Brain Council study that we did and published last year. We've got a series of publications coming out about this. Essentially, across Europe, we examined how good we are at treating depression. And this was based in a variety of European countries, from south to north, from east to west. And you can see the results here, perhaps slightly better than the Thornycroft paper. 52% of cases were detected, but of these, only 62% were treated, only 33% had good follow-up, and only 19% had access to a psychiatrist, and even less to talking therapy. So essentially, even though we do have a pathway for detecting and treating depression, and indeed effective treatment, it's not performing very well. So that sets the background to my exploration of what the potential future treatments for mood disorders are, and I'm going to go through this list over the course of the next few minutes. My own view is that many of these things are likely to fundamentally change how we detect and treat depression, and they include digital, which is a wide variety of different things, rapid-acting intermittent antidepressant treatments, and I've listed them there, ketamine, NMDA, GABA agents, and psychedelics, neuromodulation, from ECT to TDCS and vagus nerve stimulation, probiotics, and the gut-brain axis, last but not least, our old favorite, lithium. So let's start with digital. Now, digital is a wide variety of different approaches, which range from artificial intelligence and machine learning to process data, virtual reality and augmented reality for training, clinical assessment and treatment. We already have virtual reality treatment packages for example, for childhood OCD in my hospital. Social media effects on mental health. Now, this can be good or bad. We all know that with adolescent school children, there can be powerfully toxic effects of social media. We have a plethora of mental health apps with really hundreds, if not more, mental health apps. Potentially, these can be very good for health monitoring and detecting, but of course, we really await an industry standard. Therapeutic companions have been trialed in Japan for the elderly. Digital phenotyping, which I think is one of our most tractable approaches. This includes sensors and smartphones, which could give information about this, which episode of mood disorder you're in, or when you change episodes and so on, and are good measures of activity, circadian rhythm, and sleep. Neural implants are emerging, but not really going to be used in clinical practice in straightforward depression for a while, although there is work in deep brain stimulation. And of course, there is vagal nerve stimulation, which is not a neural implant per se. And lastly, there's probably more problems than potential benefits from gaming. Gaming disorders and other internet-related issues are a big deal. We have gaming clinics in London to try and treat with this. So a very rich and confusing landscape for the potential digital advances and innovation. But I want to particularly just talk about the machine learning and artificial intelligence with the Human Phenome Project. And this is something which arose from rare childhood diseases, and you can see the reference there. This is aimed at identifying specific genotypes that are associated with human phenotypes. The current approach for defining and assaying phenotypes may be inadequate, and this comes from physical medicine, but of course it's even more so in neuropsychiatric disorders. And the Human Phenome Project proposes an international effort to create phenomic databases, comprehensive assemblies of systematically collected phenotypic information, and with the aim of developing new approaches to analyzing such phenotypic data. And they're already taking part, psychiatrists are already taking part in this. When I went through it, we basically got back to Carl Jaspers. This is all about what we put in notes and how we assess patients. Jaspers, who of course really is fundamental to most psychiatric training in psychopathology, wrote this all in General Psychopathology, Volume 1. You can see that phenomenology includes a concrete description of psychic states, presents them for observation, and reviews the interrelationships of these states, and then relays them in an agreed terminology. We, of course, cannot perceive others' psychic experiences, and there has to be empathy and understanding of the external characteristics of the psychic state. Our chief help in this is the patient's own self-description, and this provides the best defined and clearest data as interpreted by the psychiatrist. Why is all this important in the age of digital phenotyping? Well, it's important because understanding our patient's experience and accurately recording them is key in my mind to having machine learning that actually produces beneficial results, further than just simple description of what drugs or side effects are on. And I think this means that our psychiatric skills in psychopathology have a real role in the digital age. Okay, moving on to rapid-acting intermittent antidepressant treatments. This is something that many of you will be familiar with. You know that our currently available treatments, from fluoxetine to olanzapine to nortriptyline, generally principally target monoamines, and you can see the cartoon here, and many of the future treatments will target the glutamatergic synapse. You can see an example here on the other side of the screen of the effect of for example, ketamine and glutamate producing a glutamate surge in the synapse, which we can actually now image, and with a downstream effect on increasing synaptic density. And there's been lots of work suggesting that the final common pathway, the final neurobiological substrate of recovery, is via neuroplastic effects, increasing synaptic density and returning the brain to health. Now, you'll be familiar with the fact that there's much data on ketamine and S-ketamine. I don't want to go through that to a great degree because that's well known to many of you in the audience. But just to give you an update from our recent New England Journal of Medicine paper that was published about a week ago, this is the ESCAPE TRD study, which was done with Janssen. 622 people who were on an antidepressant were randomized to either receive treatment with Spravato or with quetiapine for 8 weeks to the primary endpoint, which was remission, and then further to week 32 with the key secondary endpoint of maintaining the remission through that time period. And here's the main data. The percentage of patients in response and remission increased over time in both treatment groups, but was higher at all time points for patients treated with esketamine versus quetiapine. And that was true at week 8, but also at week 32, a significantly greater percentage of patients were in remission with esketamine versus quetiapine. Now, you may well reasonably say, what about other treatments, for example, lithium? Purely by coincidence, Professor Tony Clear, myself and others in the Maudsley have done a similar study comparing quetiapine and lithium. And rather surprisingly to me, quetiapine beat lithium. So we end up with these two studies with a relative ranking of the treatments of esketamine having the greatest efficacy, then quetiapine, and then lithium. So I think this is a real advance. It shows that esketamine is beneficial in this group. And the group who'd had more episodes, 3 or more, the 3+ group, the benefits of esketamine were even greater compared to quetiapine. Moving on to psychedelics, this is one of the hottest and most interesting areas of psychiatry and psychopharmacology. Psychedelics are as old as history itself, perhaps even older, but the first description of a psychedelic was of mescaline in the British Medical Journal in 1899, which was actually in our hospital. And then there was the synthesis of mescaline by Ernst Spath in 1919. The era really took a major leap forward with the synthesis of LSD by Hofmann at Sandoz in Switzerland in 1938. And then LSD was actually widely marketed for at least a couple of decades and used throughout the world. And the first publication of LSD therapy in depression was by C. Savage in 1952. And there was an establishment of an LSD clinic in the UK in 1953. Hofmann, who was a very talented chemist, synthesized psilocybin, which naturally occurs in mushrooms that you can see there. But then, of course, in the 1960s, it was associated with recreational use, had been pretty widely used in the 50s, and even some very famous figures, such as the Hollywood actor Cary Grant, were regular users of LSD, and indeed Cary Grant introduced Timothy Leary to LSD. Sandoz ceased the supply and production of LSD in the mid-60s because of concerns about recreational use, and then first in the United States, and then in the UK and worldwide, the psychedelics were essentially banned. And they went into a sort of long, dark night of the soul until they were resurrected as potential medicinal treatments, really because of the efforts of Professor David Nutt, my colleague in London, and others. And they've now been brought out and brought off the psychopharmacological naughty step where they've been for 2 or 3 decades, or longer actually, and we're now having the publication of trials because I think there's potentially real traction for this approach. So another New England Journal of Medicine paper that we took part in, this was done by my old boss, Guy Goodwin, who's now working for the company Compass, and this is really, I think, the first very credible trial of psilocybin. There have been other publications, but they've been criticized for methodological reasons. But this is a trial of a single dose of psilocybin for treatment-resistant episode of major depression. And here's the essential data. First thing to note is it's 3 doses of psilocybin, or COMP360 as it's called. The reason for not having a placebo is that all of the patients could immediately tell if they were receiving placebo or not. and therefore essentially the 1 milligram dose acted as an active placebo. The 10 milligrams was intermediate, and dose finding, 25 was the top dose. This is a one single dose study. So these were people with TRD, and you can see that the 25 milligram group had the greatest response. And in the majority of these patients who responded, 2/3, this was maintained for 12 weeks. Now, this disappointed many psychedelic devotees who expected psilocybin to cure everyone immediately and for all time. But coming to this as a psychiatrist who's studied and treated treatment-resistant depression for decades, this is an extraordinary result. You can have 30% of people essentially get better with one dose, and 2/3 of those people continue this for 12 weeks. That compares very well against every other treatment modality. But bear in mind that this is a first study. The first studies of ketamine and S-ketamine also suggested a very beneficial immediate effect, which could potentially be long-lasting from one dose. We have a whole series of further trials going on with psilocybin, and it's possible that this may be a licensed treatment in the US and the States and so on, and Europe and so on, within possibly about 3 or 4 years, if everything works. How does it work? Well, psilocybin has long been noted to promote greater functional connectivity. This may be partly through effects on neurogenesis and neuroplasticity, working through things like BDNF and TrkB, the troponin receptor kinase type B. And a recent paper from Nature Neuroscience from June this year showed that psilocin, which is the active metabolite of psilocybin, acts to actively promote TrkB dimerization and BNF binding. So this paper suggested that this may mean that psychedelics could have a big application in neurocognitive disorders, Alzheimer's, progressive cognitive decline, Parkinson's disease, MS, and many others. I think certainly the next step is to do studies at the interface of psychiatry and neurodegenerative disorders. And we are planning to do a study, for example, in late life depression, late life treatment-resistant depression, which I think would be the logical next step. Okay, so that's rapid-acting intermittent antidepressant treatment. So I want to go through neuromodulation now. Now, ECT, which has been around for 70 years, is the most effective treatment for major depressive episodes. This is a systematic review, a network meta-analysis that we published in the British Medical Journal just before COVID. And you can see biterminal ECT is by far the best, better than TMS, better than TBS, and everything else. But of course, ECT is retained for the most severely ill. It's a very stigmatized treatment, and lots of patients, even if they really need it, are unwilling to take it. But there's applications, I think, of neuromodulation at other points of the pathway. So at the beginning, at the very early stage, perhaps even in the community, we're seeing the application of home-based transcranial direct stimulation. This is done with a cap. There's various different caps. There's different companies who are actually selling these. You can buy them on the internet. The work that we've done is mostly with flow neuroscience. But my colleague in London, Professor Cindy Fu, has received charitable support for a trial from the Rose Trees Trust, and you can see the trial number there. This is the Empower clinical trial, randomized, double-blind, placebo-controlled. The placebo control is very good. People can't tell if they're receiving the real stimulation or the sham cap. 10 weeks blinded, and then 10 weeks open label with a number of sessions. Reasonable numbers, 173. We recruited from our own center and from Houston, our colleagues in Professor Jair Suarez's department. I'm pleased to see that we actually recruited more. And we stopped the trial early because the interim analysis showed a higher than expected beneficial effect size. That's the data there. And I'll just go straight on to the results. And you can see here, really quite strikingly beneficial. So 62% response using the Madras criteria, 53 using Hamilton, and for remission 57 and 44. So this compares really well for example, the STAR-D data. And I think this means that potentially there's real traction with making this as available as possible to people in the community. There was really no clinically significant side effects, and many people showed real benefit. So this is a potential neuromodulatory approach for very early in the treatment pathway for depression. At the other end, we have VNS therapy. This was approved in the EU in 1994 for use as an adjunctive therapy in reducing the frequency of seizures in patients whose epileptic disorder is dominated by partial seizures with or without secondary generalization, or generalized seizures which are refractory to antidepressant medications. And it was approved in the EU in 2003 for the treatment of chronic or recurrent depression in people that are treatment resistant or treatment intolerant. Now, there's been lots of skepticism about VNS because the acute trials over a few weeks didn't really separate from placebo. But when those people who continued to receive treatment went into registers, they showed real extra benefit. We're studying essentially as many people across Europe as we can who are receiving VNS. We've just published our baseline characteristics. We haven't published the data for the first-year outcomes because we're still analyzing it, but the preliminary indication is that the very severely ill, recurrent treatment-resistant depressive population, many people derive real benefit from VNS. How does it work? Well, like many things in psychiatry, we don't really know, but it may work via effects on neurotransmitter expression, blood flow, changes in EEG, or cholinergic. But you should bear in mind that there's a big link between the gut and the brain, and of course, the vagus nerve is the major highway for this. This may also be important for probiotics, which of course are all about the gut-brain axis. There are bidirectional communications between the gut and the brain. As I've said, there's three main pathways of communication: the vagus nerve, the enteric nervous system, then the immune system with direct contact with immune cells, release of inflammatory cytokines, and the dear old HPA axis. And a nice review from John Crine and Ted Dinan in Nature Neuroscience. The composition of the gut microbiota, which we all have, in fact, we've got more cells in our gut than we do in the rest of our body, is altered in psychiatric disorders. So this is a review by one of our PhD students who's now a postdoc. The findings of looking at the entire literature were all studies reported alterations in patients, and there was evidence of a transdiagnostic pattern of alterations in MDD, bipolar disorder, schizophrenia, and anxiety disorders, with a reduction of anti-inflammatory butyrate-producing bacteria and an increase of pro-inflammatory bacteria. Victoria also led a review. This was an updated review and meta-analysis of all the trials of probiotics for the treatment of clinical depression, adjunctive versus standalone. We found that probiotics were more effective when given with antidepressants. So probiotics significantly reduce anxiety and depressive symptoms, but particularly when administered in addition to antidepressants. Little is really known about the mechanism of action, but bear in mind these are a relatively small number of trials, many of which were done in the Far East. So this is our study, just published in JAMA Psychiatry. This is Victoria's PhD. This was a double-blind, placebo-controlled trial of a particular probiotic intervention, commercially available 14-strain probiotic, and the outcomes were acceptability, tolerability, and so on and so forth with mood ratings. You can read the actual paper, but just to say that when compared to placebo, the probiotic added to the antidepressants produced a greater reduction in depression on both inventory of depressive symptoms, the Hamilton depression, and also the Hamilton anxiety. And the effect sizes were in the moderate to high range. So this at least gives us scope for doing further large-scale studies. Again, a bit like the transcranial direct stimulation, it's the type of intervention which can be done relatively cheap deeply and at great scale in the community. So it's something that could be incorporated into our treatment pathway very early on. And this is just the CGI data, and you can see the probiotic group actually had much more people who were very much improved, and so on and so forth. And of course, it was well tolerated, acceptable, and very accessible, low dropout rate, high engagement. Over 97% of the capsules were taken as directed, no severe adverse reaction, no dropouts due to side effects, mild and transient GI symptoms, and overall both groups improved. So this was the first UK European trial to demonstrate acceptability, tolerability, and therapeutic potential of readily available and scalable probiotic. And I think we need much larger studies, but this is certainly very encouraging. Lastly, in the last few minutes, I want to finish with lithium. Now, you might say, if I'm talking about the future, why am I talking about lithium? Lithium comes from the past. It's as old as our universe, practically, being the third element in the periodic table. And you can see there it is there. Of course, it is an element, not a drug, although it's given in a drug form. In terms of the benefits of lithium, people underestimate these. This is a paper we did this year. Andrea Ulrichsen's one of our PhD students, Rebecca Strawbridge, and other colleagues did it with me. This compared the measurements of lithium treatment efficacy in people with bipolar disorder. This is the first study where we looked at every outcome measure, and 71 studies were included with 30,000 individuals. Approximately 2/3 of patients received some clinical benefit, and over 50% achieved remission. So classically, we teach our psychiatric residents that 1/3 of people do very well on lithium, 1/3 do have some benefit, and 1/3 have no benefit. But in actual fact, it probably may split 50-50, with 50% of people doing well and 50% of people not doing well. But we don't know which group people will be in at the beginning. This is the basis of our R-Link study. We finished the first one, and we're now analyzing the data. I don't have this to show you yet, but we will be reporting this over the next couple of years. This was a big EU grant, and the overall aim was to identify the eligible criteria for people with long-term treatment of bipolar disorders in terms of response, safety, tolerability, and so on. If you want to think about a simple analogy, think about breast cancer. So with breast cancer, we know that if you're estrogen receptor positive, you go down a different treatment track with estrogen receptor antagonists or estrogen receptor modulators compared to the breast cancer estrogen receptor negative. So this is all about biomarkers of response. These are our friends and colleagues across Europe, headed by Franck Bolivier in Paris, with Brune Etan, with centres in Denmark, Spain, 2 centres in the UK, Norway with Ole Andreas in Sweden, Mikael Land in Poland, Germany, Italy, and so on. And these are some of our biomarkers. So we're looking at actimetry, which I mentioned in digital. We're looking at ecological smartphone-based measures. We're looking at pharmacogenetics, molecular signals. But we're also looking at brain lithium distribution. We know that the level of lithium in the brain is not shown by the peripheral level. David Cousins has done work over the past couple of decades establishing the technique for measuring brain lithium levels using MRS. And David is now publishing papers on this. It may be the lithium responders are the ones where lithium gets into the brain. That would be very neat if that were true, and we'll report back the findings in the near future. Okay, so it's coming to the end of my lecture. Hopefully we can take some questions on the chat. This is our current treatment pathway for patients with MDD, which rests on screening for diagnosing depression, straightforward treatment with SSRI or SNRI, and then a carousel of different options with neuromodulation or psychotherapy thrown in, and then treatment for at least 6 to 9 months and longer for recurrence. This is going to be disrupted, in my view, with digital and other therapeutic approaches. Hopefully for screening and diagnosing, we'll see much more detection and early intervention with digital informed measures. We'll see targeting of treatments based on AI and machine learning and biomarker studies. And we're looking at new therapeutic options, which include neuromodulation, the gut-brain, and rapid-acting intermittent antidepressants, which target new systems such as glutamate and GABA. And what about the psychiatrist's role in this? I think that psychiatrists are key to this. When things are changing rapidly, we need people who know about the evidence. Many of my patients come to me having consulted Dr. Google and picked up the first 2 or 3 hits which they think are the most important. But I would say that for us, we should go back to T.S. Eliot and remember that we can lose wisdom and knowledge, and we can lose knowledge and information. So essentially, the psychiatrist's role is to be the person who synthesizes all these things and lets wisdom guide. I'll stop there and thank you for your attention, and I do hope you heard me.